Good morning, everybody. Welcome on this webinar, the first webinar after the summer holiday. Well, I hope you're all fine. Thank you for joining. There are about 260 people who registered for this webinar, so that's quite impressive. Well, today we're going to talk about the history of the patient, and sometimes this is something we underestimate. When you do a clinical examination of a patient, the history sometimes provides us much more information than we might suspect. Actually, soft tissue lesions are typical lesions. You don't have 100 different ways to sprain your ankle, to get back pain, to get shoulder pain. So very often you're going to hear similar things from the story, some key elements which are typical for that particular lesion. Well, today I'm going to give you a few examples. Well, in the meantime, you can introduce yourself in the chat because I'm curious where you are from. So let it know, and I'm going to start a little poll. I would like to know if we already know each other. Yeah? Is it the first time you follow a webinar of mine, or you already followed several of my webinars, or you already followed a live course with one of the GCI team members? Well, let it know. I'm curious. Okay. Christina from Slovenia, welcome. Velika from Bulgaria, first timer, okay. Super. Ricardo from Brazil. It must be very early in the morning over there. I think it's -5 hours difference in comparison to Belgium. Louis from Dubai. So we are again for this webinar east, west, north, and south, so to speak. Malaysia. Oh, fantastic. Welcome. Okay. History. Perhaps you're familiar with this TV show, Alo Alo. This used to be a very popular TV show in Europe. I don't know if it also was in other parts of the world. But okay. I'm back. Sorry for that, but apparently there was some unexpected technical problem. Murphy, things happen. After all, it's a live broadcast. Just let me know in the chat if you can hear me, if you can see the presentation, if everything is okay now. That would give me some confirmation. Yeah. Okay. So what was I saying? We're talking about the history of the patient, okay? I really think it's super valuable to take some time to really listen to the patient. I call that the investment of the first treatment. Yeah? Some people do that very quickly. The patient comes in, 2 minutes later, the patient lies on the treatment table and something is done. Perhaps it's a nicer idea to say to the patient, listen, tell me, what can I do for you? Yeah, what's your problem? And that's why the title of this webinar is Why Musculoskeletal Therapists with Big Ears Are More Successful. Okay. Next week is going to be for me a pretty intensive week. As you know, I always broadcast here from our International Training Center, where we offer the Mastermind training program. And next week, more specifically 7th September, I'm going to start a new mastermind group. Very exciting. As you can see, I have a guest from Bhutan, guest from Belgium, Venezuela, and Bermuda. Well, 7th September, I'm going to meet those people for the first time. Surprise, surprise. And then 7 days intensive training program. This is the second mastermind of this year. If you would be interested in joining a mastermind too, well, you just surf to mastermind to join. And the next mastermind will take place from 6 to 12 May 2023. Just have a look. Okay, so the question is, can you hear the diagnosis? Well, I hope you can. Let's start with one nice example. An acute subdeltoid bursitis in the shoulder. What are we talking about? Well, we are talking about the subdeltoid bursa, but in fact, there are, let's say, two parts. They're not really two separate parts, but there is a part you can palpate, the more subdeltoid part, and there is a part you can't palpate, the more subacromial part. And what is an acute subdeltoid bursitis? Well, that's an inflammation of this complete total bursa. So the subdeltoid part and the subacromial part are really very nicely inflamed. Well, I have a question for you. If you look at the right side of your screen, an acute shoulder bursitis reacts well on manual therapy techniques. And I'm going to publish it, and now you should see it if everything is okay. So an acute shoulder bursitis reacts well on manual therapy techniques. Yes or no? Okay. All of you say, no. Okay. 85% is saying, 75% is saying no, 25% is saying yes. Interesting to know, but the no voters are in the majority. Well, of course, an acute bursitis will not react very well on manual therapy techniques and mobilization techniques and so on and so on. There is another treatment strategy for this kind of problems. But the story, I promised you the story, okay? What is this patient going to say? How did it start? Well, it started spontaneously. I just woke up with it, just as if the patient got a present from the gods. I have pain. Perhaps there was a trauma, perhaps there was some overuse. And the first day, he has quite a lot of pain, and he has limitation of movement on elevation. He says, uh-oh, I have a problem on elevating my arm. The second day, more pain, more limitation of movement. The third day, constant pain, a lot of pain. Serious limitation of active elevation. And where is the pain? Well, the pain is going to be along the entire C5 dermatome. Yeah, so they have pain all over the arm until the base of the thumb. So this is a pretty clear story. Yeah. Day one started spontaneously, some pain, some limitation of movement. Day two, much worse. Day three, not pleasant anymore. You may practically be sure that this patient on day three, he's certainly going to call his doctor because it really hurts too much. Okay, when I said that manual therapy techniques are not the best strategy in that case, well, according to our experience, the better strategy is going to be, or the more efficient strategy is going to be a series of specific infiltrations in the subdeltoid part and the subacromial part of the bursa. And that really gives relief to the patient pretty fast. Okay, another example. An internal derangement in the knee. Well, I have another question for you. Let me get it over here. Okay. And the question is, a loose body in the knee is visible on medical imaging. Manipulation will be successful. What do you think of that? It's more or less 50-50 now. Yeah. Okay, 60% says no. Okay. Well, can you manipulate when the patient has an internal derangement? Would that be a good idea? The question is yes, or the answer is yes. But if the loose body is visible on medical imaging, in other words, it's a bony loose body, then manipulation is not the best idea. The best idea is going to be to remove that, so the patient needs to get an arthroscopy. Keep that in mind. If you hear the loose body, but you don't see it, then it's okay, suitable for manipulation. If you hear it and you see it, then we have a little problem. Okay, what do you hear in the story? The age of the patient. You don't think of a patient of 25 years old. Your first idea is that probably it's going to be some elderly patient. You think of 60, 65, something like this, or even older. And what is the patient telling to us? Well, the typical things that I have twinges. Unexpected, twinge, and then it goes away. Or the feeling of giving way, you lose control over your knee, or the feeling of a temporary locking. Suddenly, that's strange, I can't fully extend my knee anymore, or I can't fully flex my knee anymore. Perhaps they're also going to notice some minor swelling, and specifically with elderly patients, they very often say they have some insecure feeling on going downstairs. Instead of going downstairs just like this, they go downstairs step by step because they don't trust their knee anymore. Actually, this is the same story of a symptomatic meniscal problem, but then most likely the patient is going to be a little bit younger. Okay? So you can hear it, but if you don't see it on medical imaging, then yes, we can do some manipulation technique. By the way, later in this webinar and in a few minutes, I'm going to show you a new project I worked on during the summertime, and I'm going to share you a story about the so-called loose body manipulation, which was not very successful, but that's for later. Okay. Actually, typical with loose body manipulation is that we're going to do some kind of maneuver under traction. We're going to do some rotation maneuvers under traction. Actually, we're going to change the intra-articular pressures. Because of that, we can, let's say, change the position of the loose body where it doesn't interfere anymore with joint mobility. This is hypothesis, yeah. But we see clinically that okay, the symptoms of the patient improve. Okay, so we had an acute bursitis. We had an internal derangement in the knee. What about an internal derangement in the spine? Well, of course, then I have another question for you. Let's have a look. Okay. The question is, radiating pain in the leg until the foot mostly is the result of a sciatica. What do you think of that? Let me know. Oh, okay. We go again in the direction of hola. Yeah. 80% is saying, oh, now it's half-half, more or less. Yeah. A small majority for the no camp. Well, for those of you who already followed my lumbar spine courses or my online courses on lumbar spine, then you know that in most of the cases when the patient has radiating pain in the leg, that in many cases this is not the result of a real sciatica, but very often this is related with multi-segmental pain from the dura. So that's quite interesting to know, but then I refer to the other webinars and the other online courses because the treatment strategy for somebody who has some discodural internal derangement versus disco-radicular derangement, so sciatica, the treatment strategy is quite different. But okay, let's go back, as I promised, to the history. How did your complaint start? Well, many patients, they say that, well, suddenly I was doing a certain movement and suddenly I got a twinge in my back. Other patients say, I was working in my garden all afternoon yesterday, and slowly but surely I felt my back, and then in the evening, I felt my muscles. And then the next day, this morning, I woke up and I said, oh, what's wrong with my back? It's worse. Both stories are pretty popular, and more specifically, the sudden story is very typical for internal derangement. And what you very often hear is the component of flexion and rotation. If you ask the patient, how did it start? Which kind of movement were you doing? Very often you hear they were in a flexed position with some rotation, and then they go back to extension, and then suddenly, chaka. This is really super frequent. You can also ask them what happens when you cough or sneeze. Yeah, and then acute back pain patients, they very often say, oh, sneezing. Oh, no, thank you. That really hurts in my back. That's just as if they put a knife in my back. No, that's typical for an acute internal derangement. But the story can tell you more. Where do you have pain on squeezing or coughing? Do you have pain in the lumbar area? Do you have pain in the gluteal area? Or do you have pain in the leg? If the patient provokes pain in the lumbar area, then you have a big chance that this is in relation with the discodural conflict and internal derangement. If the patient is specifically having gluteal pain, there could be a relation with a sacroiliac arthritis. And if the patient is describing pain in the leg, then that could be a sciatica, but it also could be something you don't want. It could be a neuroma. So keep in mind, when you ask to the patient what happens when you cough or sneeze, don't forget to ask to the patient, where does it hurt? Okay. And of course, something you see, you hear so often in the story, where is your pain? And the patient says, well, my lower back there on the left side. The next question is, did your pain start there? Was your pain since the beginning there? And then many patients say, yeah, well, at the beginning, I had pain in the center of my back. But since a few days, this back pain and perhaps gluteal pain disappeared and I got leg pain instead. What is that? That's a shifting pain. And typical in the spine, shifting pain is always 99.9% of the cases an internal derangement. Facet joint dysfunctions, sacroiliac dysfunctions, ligamentous problems, muscular problems, they never cause a real shifting pain. So you ask the patient, what do you feel now? And did it start over there? So if you hear in the story a shifting pain, you have a very big chance that we are talking about an internal derangement. For further details on that topic, of course, I refer to my other webinars and my other online courses. And I briefly mentioned it before, the question in the poll. The patient has leg pain. Is this leg pain always coming from a sciatica? The answer was no, for the simple reason that a lumbar discodural conflict can cause multi-segmental pain. That means radiation of pain in several dermatomes at the same time. And if you look at the lumbar dura, the pain can radiate until the feet. Yeah? So you can have leg pain all over the place, which is not related with a nerve root, but it is more related with dural reference. Okay? Okay, when the patient has an internal derangement, and in certain cases we can do some manipulation techniques. If you want to find out more about manipulation techniques, on my website you can find a lot of information about that. Okay. Something new. I told you that during summertime I was working on another project, and I would like to show that to you now. All of us, most likely, we are connected in some social media groups and some Facebook groups, professional groups from therapists. But what is the problem? What is the problem, for instance, with Facebook? If you post something, not everybody who has to see it will see your post. And Facebook is determining what you're going to see, not you. Facebook is determining. So that's a little bit unpractical. And then I thought, is there an option to create a platform where all of us, professional therapists, where we can connect, where we can share ideas, where we can discuss together in a safe environment? And yes, this option exists now. And I would like to invite you to join the Orthopedic Medicine Connection community. I'm going to try to share my screen, and then I show you what it is about. Okay. So you go to orthopedicmedicine.eu, and this is in fact our online learning platform. But I've added two things. If you would like to know where we have some events, some courses in the future, you just click on events, and here you will see our complete program for the next months, and you just click on the link to get more information. But community. This is the new thing I created, but without your help, it's not going to function. So I invite you to make a free account, join the community, and we have different sections. If you have a patient and the clinical image is not 100% clear, well, you just can post it in the community and you're going to get an answer from me and some other colleagues. If you would like to know something about therapy strategies, or you have a success story you would like to share with us. And a few days ago, I added this section, the daily life of a musculoskeletal therapist who once thought he was the one. In other words, it's about me. And I posted a first article, how I really screwed up a patient in 1991. Well, take some time to read the article. Yeah, it's a funny story, but the consequences for the patient were not that so funny. So have a look at that. And when you are joining the community, automatically you also get free access to the free online discovery course and some extra online content. Okay, voila. So yeah, I invite you to join the community. It's free. You don't have to pay anything for it. So go to orthopedicmedicine.eu and make a free account. Okay. And now I have to activate my presentation again. So voila, here we are. So Orthopedic Medicine Connection Community, orthopedicmedicine.eu. Okay, good. Tennis elbow. I think we are all familiar with tennis elbows. We see that very often. A tennis elbow can be the result of a local problem, but it could also be the result of a referred problem. It could be connected with cervical problems. It all depends on which definition do you give to the tennis elbow. I once read that in literature there are about 27 different definitions and interpretations of a tennis elbow. Okay, well, I have another question for you. Let's have a look. Okay. And here it is. An acute tennis elbow causes limitation of movement of the passive extension. Yes or no? An acute tennis elbow causes limitation of passive extension movement. What do you think? Yeah, there's at this moment a majority for the no group. 80% more or less says, no, that's not correct. Yeah. Okay, almost 90% says that's not correct. And of course, you are right. Yeah, an acute tennis elbow will not cause limitation of passive movement, passive extension. It's possible that the passive extension is painful, but it is not necessarily limited. And what do you hear in that tennis elbow story? Well, sometimes it's very easy. The patient comes into your practice and you shake hands, say, welcome, good morning. And you shake hands and the first thing the patient, oh, my elbow. Okay. Then you already suspect a nice acute local tennis elbow. Where do they have pain? They have pain, the lateral aspect of the elbow. It could radiate all the way down. It could even radiate in some fingers. And most likely it's going to be the result of a repetitive strain injury. When you talk about a local tennis elbow, doing the same movements all over again, overuse, Yeah. And what are they telling in the story? Well, with an acute tennis elbow, they have a problem to open a jar of jam, for instance, at breakfast. They have a problem pouring out coffee or whatever. Sometimes it's so so acute that they just drop things. Yeah? Working computer could also be problematic, but if they start dropping things, it's a pretty acute tennis elbow. So this story again is also pretty typical for this patient. And of course, when we talk about a local tennis elbow, then we have to determine which type of tennis elbow. Some people describe 5 different types, other people describe 4 types, but you can only come to that conclusion by using, let's say, a good specific palpation technique. Yeah? And this palpation technique is also going to be interesting later on if you decide to treat. Let's say you would like to do shockwave. Well, you better do shockwave on the right spot, or you do some needling techniques. You better do the needling technique on the right spot. Yeah. Okay, more about the palpation, of course, in our further online programs. Good. A next example. Well, perhaps before I go to the next example, do you have any further questions for me at this moment? Do you have any suggestions, any problems, any situations where you experienced a problem in your daily practice? Just let it know in the chat. There is some when you type something in the chat, there is some delay before I see that over here. So I'm going to wait a few seconds and see if something appears in the chat. If you have inspiration, yes or no. And if you don't have inspiration at this moment, remember, join the Orthopedic Medicine Connection community and just post there whatever you would like to post in relation to orthopedic medicine. Okay, carpal subluxation. What is the patient saying? If you talk about, you have 2 types of subluxation. You have a dorsal carpal subluxation and you have a palmar subluxation. But the most frequent subluxation is going to be the dorsal one. What is the patient going to say? Well, he's going to say, "Oh, I have a problem. I have a problem with dorsiflexion. Dorsiflexion is painful, is somewhat limited." Yeah? For instance, when they get out of bed in the morning, they push with their hand on the bed. Oh, that's problematic. Yeah? It's painful end range. If there's a limitation, there's a small limitation. And what you also hear in the story is that there is some kind of repetitive strain. You see that very often with, for instance, cleaning staff or people who work in a factory and constantly do the same movement all over again. But it could also be the result of a flexion trauma. And when there is a flexion trauma, then you can also not only have a carpal subluxation, but you can also sprain one of those dorsal ligaments. But you can expect that I have another question for you. Where is the carpal subluxation question? Well, here it is. The question is it useless to manipulate a recurring dorsal carpal subluxation? What do you think of that? Is it useless to manipulate a recurring dorsal carpal subluxation? Okay, the different opinions again. In the meantime, I'm going to do some hydration. 66% thinks it is useless to manipulate a recurring dorsal carpal subluxation. Already 70%, 66% again. Well, the answer is yes, it is useless. You can manipulate, and the patient is going to be better. But probably a few hours later, everything is back to subluxation again, so to speak. Yeah. Why? Well, a patient who has a recurring subluxation, and in the story we heard a flexion trauma, probably has a rupture of some of those dorsal ligaments, causing instability over there. And because of this instability, you constantly have carpal subluxation, repositioning subluxation. So, okay, you can manipulate, but it's not going to be the solution. So the solution is going to be to manipulate, and then immediately afterwards, when it is reduced, don't move. And then the doctor is injecting or is giving sclerosing injections in those ruptured ligaments to create in an artificial way adhesions to make this area more stable again. And that works pretty fine. Okay, it's a little bit rape of nature, so to speak, but that works fine. But before giving the injection, make sure the carpal subluxation is reduced. And there are different ways of performing manipulation. We have five or six different options, and you choose the option which works the best for you. What you see on the images, for instance, on the right side, a specific technique, we take a contact on capitate, we take a contact on lunate, because mostly when there's dorsal carpal subluxation, it's going to be the capitate bone, mostly. We just separate or try to separate an under traction, intensive antero-posterior glide, and then we check the dorsiflexion to see whether we were successful, yes or no. Okay, and then another story, a traumatic shoulder arthritis. And of course, there is one more question for you. An acute shoulder arthritis reacts well on manual capsular stretch techniques, yes or no? Okay, the score is now exactly 50-50. And then we go to 75% for the nose. And it's 50-50 again. Okay, so I love it like that. Actually, this is a little bit a similar story as the acute bursitis I was talking about before. Yeah? An acute shoulder arthritis, if we do capsular stretch techniques, this is exactly the same as torture. The patient is absolutely not going to support that. Yeah? This is way too painful. We're going to do something else. But again, the story. Where is the arthritis coming from? Well, in many cases, it just started spontaneously. Again, the patient woke up with pain in the shoulder and some radiating pain somewhere in the C5 dermatome. Perhaps there was a trauma. Perhaps there was overuse. Perhaps it was just a present from the gods. In an acute case, there's going to be a lot of radiation of pain. The more radiation of pain, the more acute the problem. So they can have pain all the way down until the base of the thumb. They also will have constant pain. So the patient is sitting in front of you in the clinic and He's not doing anything. He's just sitting there. And you ask to the patient, what do you feel now? It hurts. He's now 5 minutes without pain. Lying on that side is impossible. And of course, his function will be seriously disturbed. Yeah, he's going to have a lot of problems with elevation. He's going to have a lot of problems with the rotation, more specifically lateral rotation and medial rotation. Yeah, putting his arm in the sleeve of the coat, for instance, or closing the bra. Those kind of things are becoming very, very problematic. So again, here you hear some interesting things. Actually, a traumatic arthritis in the shoulder has kind of a spontaneous evolution. Imagine you don't give any treatment at all, just nothing, or the patient is not looking for any treatment. It can take up to 1 year, but during this 1 year, we have different phases where the patient has more pain and limitation of movement or less. The treatment strategy can be a little bit different, but there are other types of arthritis which can take about 2 years. If you want to find out more about that, well, make an account in this orthopaedicmedicine.eu, the connection community. And in the free discovery course, I think there is an extensive lecture about arthritis in the shoulder. Just have a look. This is quite interesting for us. I'm going to enlarge the image a little bit for you, then, so it's going to be even more clear. We have different stages in an arthritis. You have an arthritis light, which is a stage 1. An arthritis heavy is a stage 3. And then we have some kind of combination. The story is going to tell you if the arthritis is light or heavy. And I come back to the previous questions. Do you have a lot of radiation of pain below the elbow? Do you have constant pain? And can you lie on that side? Well, what are we going to do with those 3 questions if the patient gives you 3 favorable answers? I can lie on that side. I don't have constant pain. And I don't have radiation below the elbow. This is an arthritis light, stage 1. The opposite. The patient gives you 3 unfavorable questions. I do have constant pain. I cannot lie on that side. I have a lot of radiation that goes further than the elbow. That's a stage 3. The treatment of a stage 1 and the treatment of a stage 3 is not a little bit different, but is totally different. The 2 different worlds. So that's why the history is so important, so that later on in our treatment strategy, we don't make any mistakes we can avoid. Yeah? I refer again to that lecture on shoulder arthritis, which is on the online learning platform. Okay? Voila. Everything clear for everybody? Yeah? Okay, perfect. What you see over here, for instance, is one of the treatment techniques we can use for shoulder stage 3 arthritis. So for this acute arthritis, we're going to do some kind of distraction technique. We're not going to mobilize, but we're going to focus on slight distraction with some kind of vibration. Yeah. Okay, so as usual, I try to keep my webinars within a time frame of 1 hour. So I'm very happy that you take the time to join this webinar. But I don't want to overload you, because it's Saturday. You certainly have some other nice things to do today. But if you would like to have more information about our international courses, well, I already showed you on orthopaedicmedicine.eu. You can find our international planning, and perhaps there's a course in somewhere in your neighborhood. You never know. Okay. If you have any further questions, then now is the moment. If you go to cyriax.eu, you can find all the details about the diploma course. What is the content of the course? What exactly do we discuss? So have a look over there. You will find also a lot of extra information, more specifically the knowledge bank. And this is also something new, and if you allow me, I'm going to share my screen again with you. Okay, and then I go to cyriax.eu. If you go to the knowledge bank, then you're going to find a lot of articles over here about clinical reasoning, diagnosis, treatment, a lot of things. And some time ago, I even added the scientific references boutique. If you click over here, then you're going to find a whole range of references with the link to the specific article. So in the knowledge bank, I think you can find a lot of useful background information. And it's, of course, it's all for free. Okay, do you have any further questions at this moment? Because now is the time. Be my guest, okay? Well, then I just can conclude with one interesting idea. Are you ready to implement all of this in your clinical practice? And I have a final question for you. I'm curious, more specifically in relation to further webinars I'm going to give. Tell me, what is more your cup of tea? What is your preferred area when you talk about diagnosis, clinical reasoning, treating patients? What do you like the most? Shoulder, cervical spine, lumbar spine, knee, hip, elbow? And of course, lumbar spine is one big hit. Yeah, wow. Yeah, yeah. The knee is also pretty popular, but yeah, lumbar spine 50%. Yeah, shoulder, lumbar spine is still the number one, and elbow is the less popular one. Yeah, okay. Shoulder, cervical spine, lumbar spine, and hip. Well, that's nice. Well, okay. When you go to the orthopaedicmedicine.eu, then to the connection community, there you're going to find a lot of lectures on the lumbar spine, the cervical spine, the shoulder, the knee. You're going to find a lot of information. But the most important thing is, okay, you can follow as many courses as you want. You can have as many certificates as you want at your wall. But if we don't do anything with it, then yeah, then it's a little bit of waste of time. So I hope that today I was able to give you a little bit of an inspiration, and that you are able to implement some things in daily practice. And to help you even more, then there are two website addresses which could be interesting for you. But I'm going to have a look at the chat because Laura has a question. I have a question about dural pain. Since dura doesn't radiate into the arm, how about dural sleeve? For example, if we have a root compression on C7 due to the protrusion, does the patient feel pain even in the arm and fingers? That's a very nice question, Laura. Thank you. Yes, there is a difference between the dura itself and the dural sleeve. indeed, when there is compression on the C7 nerve root, and this compression already exists for some time, then the patient is going to have pain somewhere in the C7 dermatome, possibly radiating in those middle 3 fingers, which are part of the C7 dermatome. Yes, indeed. But when there is a, let's say, discodural conflict in the cervical spine, then the radiation of the dura mostly doesn't go further than more or less over here. This is still an empirical element. We still don't know what the exact reason is for that. Exactly the same with the dural reference in the foot. There is no reference of dural pain in the foot. It stops at the ankles. We don't know exactly why. I hope this is an answer to your question. And if you look at the right side of your screen, then you're going to see that there is a link to the Yes page. If you click on this Yes page, then you're going to arrive automatically at the Yes page on our website, and then you're going to see what happens over there. But this is a pretty nice opportunity for you to have access to the complete content of the orthopedic medicine course, including a lot of extras, a lot of downloads. Just explore it yourself, have a look. But as you can see, you don't have much time to do that. I give you 1 hour and a half to enjoy the offer I make for you. Okay, so any more final questions? So we're talking 53 minutes now, so nicely within the hour. So if you have any further questions, now is the moment. I'm going to wait a few more seconds. Okay, well, then I think it's time to conclude this webinar. Thank you very much for joining. You're going to, for those of you who were not live, you're going to receive, everybody's going to receive a replay link, so you can watch the webinar again in replay mode, and the link is valid for 1 week. After that, the webinar is going to be on the online learning platform, as well as my 13 previous webinars. You can watch everything over there. So thank you very much for joining. I wish you a very nice weekend. Enjoy the day, and talk to you on another occasion. Thank you. Bye-bye.